So, good evening, friends. We warmly welcome you for this session of the postgraduate clinics. We have eminent faculty joining us today. Professor Vivek Srivatsa from the IMS BHU, Dr. Ejuta from Tata Memorial Hospital, our own faculty, Professor Kanna sir, Jailal sir, Rajiv sir, and other senior faculty who have joined today. And we have two important exam cases for the discussion for this evening. A case is of multinodular goiter, which is presenting in a very unique way of presentation. And we have bilateral carcinoma of the breast, which is again quite sometime we discuss in our postgraduate clinics. So friends, we have the honor of having Dr. Ejuta, who was one of the presenter at the early part of 2020. We are happy to note she has moved up in her academic career as a qualified breast and endocrine surgeon, and right now she is doing her advanced fellowship at the Tata Memorial Hospital. So friends, we warmly welcome all the faculty, and we request Dr. Madhivadni to start sharing her PowerPoint and start her presentation. Madhivadni, first you should introduce yourself, your unit chief, your head of the department, and start your presentation. Go to the first slide, Kana. Faculty, kindly take over.
We can start with the presentation now.
Yes, sir. Dr. Madhivadni, do you have some challenges?
Sorry, sir. Good evening all. Sir, am I audible, sir?
Very well, ma, very well. Good luck to you.
Okay, sir. Thank you, sir. Thank you. Good evening all. I want to thank Kanangvel sir and our beloved HOD, Dr. Jailal sir, for this wonderful opportunity. Myself, Dr. Madhivadni, third year postgraduate, Kanyakumari Medical College. My HOD is Dr. Jailal sir, unit chief, Dr. Smati ma'am, and my assistant professor, Dr. Vivek sir.
Can you come little closer, ma? Your audio is little down. Can you come little closer?
Okay, sir.
And I could also see one senior faculty here. Sir, I'm sorry, I'm not able to identify you. Please introduce yourself, sir. I think he is not able to mute himself. Fine. Please start, Dr. Madhivadni. Good luck to you.
Okay, sir. Thank you, sir. A 45-year-old male patient of low socioeconomic status, a resident from Kanyakumari, presented with the chief complaints of swelling in the left side of neck for the past 3 months. He also had the complaint of a discharging sinus in the right upper abdomen for the past 1 month. History of presenting illness. The patient had a history of swelling in the left side of the neck for the past 3 months, which is insidious in onset, gradual in progression, not associated with pain, not associated with fever. The patient came to know about the swelling in the thyroid region after admission in our hospital for the past 10 days. No history of any hyper or hypothyroidism features. No history of difficulty in swallowing. No history of any dyspnea. No history of hoarseness of voice. No history of syncope. No history suggestive of Harness syndrome. No history of cough or hemoptysis. No history of jaundice. No history of any swelling in the scalp. No history of any ulcer in the oral cavity. No history of any nasal discharge or epistaxis. No history of any air pain. No history of any evening rise of temperature. No history of any loss of weight. Loss of weight present. 10 kgs in 3 months. No history of any loss of appetite. History of tooth extraction for dental caries present. No history of any radiation exposure. The patient also had the complaint and discharging sinus in the right upper quadrant for the past 1 month. It's mainly because of the history of he had a previous history of admission in a private hospital for abdominal pain and was diagnosed to have a liver abscess and was treated with percutaneous pectoral drainage. Now, he is presented to our hospital with the complaint of discharge from the drainage site in the right upper abdomen for the past 1 month. It is copious yellow purulent discharge, not bloodstained, not foul smelling. Now there is no active discharge for the past 1 week after treatment in our hospital. No history of fever, no history of abdominal pain, no history of jaundice, no history of vomiting. No. Then past history. Patient is not a known case of hypertensive, diabetes, asthma, epilepsy, or thyroid disorders. History of epithelial drainage for liver abscess done 3 months back. No history of any other surgeries in the past. Personal history. The patient is taking mixed diet. Sleep pattern is normal. No history of any constipation or loose stools. Bladder habits unaltered. Known beaten nut fever for the past 10 years. He is not an alcoholic or smoker. So summary. A 45-year-old male presented with the complaints of swelling in the left side of neck for the past 3 months, with swelling noticed in the thyroid region since admission in our hospital for the past 10 days. Now, the patient presented to our hospital with the complaint of the discharging sinus in the right upper quadrant from the previous epithelial drainage site for the past 1 month.
Okay, right. Yeah. So can we discuss it at this moment after the summarization of the history?
Go ahead.
Okay,
Sir,
okay.
go ahead.
So Dr. Madhi, I think you elaborated very nicely in your history. Only thing was a few things were not, would not come into a seamless presentation. Like every sentence you repeated, no history of, that was probably superfluous. You should say one time only, no history of, and then enumerate all the things.
Okay, sir.
And then there, in between the no histories, came one history of weight loss, which I think always is a very significant history. And was this weight loss significant or it was not significant? And how do you define or how do you say that there is a significant weight loss?
Loss of weight of 10% weight in 6 months, sir.
Okay, so what was this with this patient?
Sir?
How much weight did he lose?
10 kg, sir.
10 kgs.
Previously, he
Okay.
is about 72 kgs. Now he is in 60 kgs. 62. Yes.
Okay. So that is quite a significant history. Now you should tell it in the presenting illness itself. So
Yes,
what do you think is the cause of this weight loss? Is he having a normal appetite? Weight loss, once you are having something thyroid which is there in your mind or in the history itself, then what about the appetite of the patient? Did you elaborate something on the appetite?
In hyperthyroidism, there will be.
What was there in this patient?
This patient is in euthyroid state, sir.
How was the appetite of the patient?
The patient is telling he is having the normal appetite, sir.
So, in spite of having a normal appetite and adequate diet, he is still losing the weight.
Yes, sir.
Okay. And based on the history, can you just make something which can fit in both this history, 3 months history of neck swelling, then 3 months back history of some abscess drainage of the liver, then 1 month copious purulent discharge yellowish. What comes in your mind with this history?
Both are related to each other, or you are trying to think as separate?
I think they both are separate etiologies, sir. It's a.
But this is always advisable that you keep one diagnosis and explain that, is it?
Yes. First, try to make one diagnosis and explain both the things. Then always there is a possibility of having two diagnoses. But first, always should make both the presentations because the history is only 3 months for both of them. So, what do you think?
What do you think is the neck mass?
It can be a malignant growth, malignancy.
Can it be related to the pathology that you've described? the other for which he was admitted?
Mm, I don't think so, ma'am.
If there is a neck swelling with a purulent pus discharge from the liver for which you inserted a pigtail,
Yes, yes, ma'am.
can it be something else?
Metastasis.
What kind of you said liver abscess, no? What kind of liver abscess are you thinking of in this patient?
Any patient is a non-alcoholic, sir.
No.
So I
Without
think
any
some
history of fever, without any history of pain abdomen like that. There was no history of fever, I think you said that.
yes, sir, no history of fever, sir.
With history of significant amount of weight loss.
Could you go to your first slide? Just go back to your slides, to your history slides. So there are two things. There's a swelling on the left side and there's a sinus, which is an abscess, established abscess. So can there be a primary source of infection from somewhere?
Sir, I couldn't understand, sir. The swelling is in the left side of the neck, sir. This discharging sinus in the right upper abdomen.
Right. So if there is infection somewhere, can it go to some other areas?
Yes, sir. Tuberculosis.
Yes, why not?
Yes.
Now, what is preventing you from saying it is a tuberculosis? It may be a tuberculosis.
Whether right or wrong, you should not take time. You should answer and then go ahead. If you don't take time.
So it is a lateral neck swelling. So I consider it can be as a tuberculous node.
What is the commonest neck swelling?
Yes.
You know, if you look at all the swellings in the neck, which is the commonest one? Which is the commonest neck swelling?
Structure wise, you may not talk about pathology structure, which anatomical structure comprises the commonest cause of neck swelling.
Is the lymph nodes.
Okay, Dr. Mathani, look, there are lymph nodes in the neck, right? Is she there? Hello? Is she there?
No.
Yeah, she's there.
Yeah. Dr. Mathani, she's not answering. Dr. Madhi.
Madhivathani.
Dr. Madhivathani. There are lymph nodes in the neck. You unmute yourself, please.
Yes, sir.
Right. There are lymph nodes in the neck, no, which are very common. What everyone is trying to tell you that you should say that the commonest structure which can give swellings in the neck are the lymph nodes, cervical lymph nodes. Are they or aren't they? You have to keep an open mind, Dr. Mathwani. Right?
Okay.
One. Now answer first.
Now there is a sinus is there. Okay, somewhere in the abdominal wall. So there is a sinus is there in the abdominal wall, and there is probably a lymph node in the neck. So can you correlate that with the weight loss?
And the tuberculosis etiology, sir.
Yeah, so keep that, you know.
Yes.
So by that you can explain both the things by one diagnosis. I may not be correct, but that should be the common gesture which should be there, that you are going to keep one diagnosis, and to explain that you will say probably the patient has the tuberculosis, which is causing the sinus in the abdominal wall, and it is also causing the cervical lymphadenopathy.
No.
Okay. Yeah.
Okay.
Okay. Go ahead.
Okay, next slide, please. Next slide.
Your examination slides now.
No, I just want to just question her a bit on the
Okay.
history.
Okay, I'm
So-
sorry.
So, patient came to know about swelling in the thyroid region after admission. Okay, how did she come to know about the thyroid swelling in the thyroid region? She didn't notice it before that. Why did she come to your hospital?
Hello?
Can you hear me, doctor? Why did the patient present
Yes,
to
sir.
you in
Now
the
I can
hospital?
hear.
Right. So why did she present? Did she present for this?
Sir, the patient,
Because you came to know about swelling of in the thyroid region after admission.
yes, sir. The patient
So what
mainly
was-
presented for the sinus discharge from the upper abdomen, sir, from the previous
Right.
pictal drainage site.
Right.
Then
So
we noticed the swelling in the neck region. Then we asked the history about the swelling in the lateral side of the neck, sir. Then an
Right.
examination only we noticed the thyroid swelling, sir.
Hang on. So she's come primarily for this discharging sinus. That's the main
Yes, sir.
complaint, right?
Yes, sir.
That's the main complaint.
Yes, sir.
So during examination, you noticed that she has a swelling in the neck,
Yes, sir.
right? So her primary
But-
problem is this, right? Go on, please.
So then
Sir,
that is
yes, sir,
not the chief complaint, isn't? No, go to the chief complaints. Go to the chief complaints. Yeah, so that
So
is not
if-
the chief complaint, isn't? Swelling in
Sir,
the
this
left side of
patient-
neck for 3 months is not the chief complaint. His complaint is discharging sinus in the right upper
discharge
abdomen.
sinus, upper
But
abdomen.
you have
Yes, sir.
found during the examination that there is a swelling in the neck.
That's the next swelling, sir.
So that is not the chief complaint. No?
Yes, sir.
Okay.
So subsequently, you say
What
that
do you
when
mean, what do you mean by chief complaint? What do you mean by chief complaint? What do you mean
What
by
brings
chief
the-
complaint?
What brings
So
the
is that
patient to the hospital?
The neck swelling has brought the patient to the hospital?
No, sir.
No, then you should not come into the chief complaints. The chief complaints only you should say that. Then you can add that's only the incidentally you have found out something like that.
Okay.
so
sir.
you take your history that she came with this discharging sinus, you describe the whole thing, and then you say that I noticed the swelling in the neck, and then this is the history. Okay?
Okay, sir.
Okay, next slide, please. So now you have to take the history to find out what is this discharging sinus all about, which you've said that it's a liver abscess for which pigtail has been drained, right? What
Yes,
about the
sir.
neck swelling? What do you think is the neck swelling? Is it a lymph node or is
From
it
the
a
history,
thyroid?
from the history alone, I consider it as a neck swelling, lymph node, sir.
Okay, so from history you think, because when you see the patient and you take the history, did you see the swelling in the midline or in the lateral portion?
Sir, swelling is. Can I show the picture of the patient, sir?
Yeah, please.
Yes, sir. So this
Okay,
is the
so he's
swelling I was talking about.
Right, this is the swelling, right?
Yes, sir.
So this is
Yes, sir.
obviously, I will never think of it as a thyroid. I will always think
Yes.
of it as a cervical lymph node,
Yes, sir.
and I'll take history according to that. So what made you take this history for thyroid, hypo and hypothyroid? Why did you take, just
Sir,
go back to your,
sir, on examination,
that's fine. So, okay, you can take history for hypo or hypothyroid, but why do you think, okay, next slide, please. Now you're taking history for thyroid malignancy or for any area in the draining area of this cervical lymph node.
yes,
Right.
sir. Yes,
And
sir.
you didn't find anything in your history other than weight loss in spite of good appetite.
Yes, sir. Then in examination only I found out the thyroid
No,
is
no,
also enlarged.
we'll come to the examination later on. We just want to
Okay,
sort your
sir.
history out. So
Okay.
she's got nothing except a lymph node here and a sinus here and loss of appetite.
Yes,
Right?
loss of weight. Yes,
So
sir.
now let's have your differential for this. One people said it's a tuberculosis. Right?
Tuberculosis etiology.
Anything
Yes, sir.
else can you think of? Couldn't it have been a secondary in the liver with secondaries in the neck leading to a sinus?
It can be,
Can
sir.
it be or can't it be? Can be.
Sir,
Right?
but okay.
So, right, it can be. You can, what is known as clinically unknown primary. I can't find a primary. I got a secondary here. I got something here. Right?
Okay.
So, right. So,
Do you,
please, sir.
do you think that
One more thing.
tuberculosis is such a large liver abscess?
Sir?
Is it a common presentation of the tuberculosis of the liver to present as a large liver abscess and with a single sinus?
No, sir.
What will be the history of, suppose you are thinking it is a tuberculosis of the tuberculosis that cause for the liver swelling? What will be the usual presentation of the tuberculosis abscess of the liver? When you are putting the both as a single diagnosis, that is mandatorily, we expect you to put a single diagnosis. But have you at least done any homework on to read what is the tuberculosis of the abscess of the liver, how it will present? Is it a common presentation? What will be the clinical features of the abscess of the liver? What will be the finding? No, that is mandatory. So that is what we expect in a postgraduate. When you are coming present, a rare case, we want to correlate. Now, tuberculosis abscess is a very, very rare finding. It is very unusual to have a tuberculosis abscess, but incidentally, we will have some few cases we can have still. But if at all it is presenting like this, a sinus, you get a multiple sinus. But this sinus may be due to the pictile appearance, what we are getting. And it is a very typically present like a solid mass. It will present like a solid lesion than as a liquid liver mass, what we are able to feel. No, it is away from that. But when you are putting that, but it is naturally you need to think as a single cause tuberculosis. But it is the necessity that you should study what is tuberculosis of the liver and how the tuberculosis will affect the liver.
Okay, sir.
One other thing I want to clarify is you said that you noticed the swelling 10 days back when you admitted the patient, but you have written in the history that it's there since 3 months.
Ma'am,
How did
I was telling the lateral neck swelling is presenting for the 3 months, ma'am. But the patient is not aware of the thyroid swelling, ma'am. The patient is also having the enlargement of the thyroid, ma'am.
there are two swellings? There are two swellings present.
Yes, ma'am. Thyroid also enlarged. This swelling is also present in the lateral side of the neck, ma'am.
So patient noticed the thyroid swelling, but not the lateral swelling which was present.
No, ma'am. He noticed only the lateral neck swelling, ma'am.
Okay, he did
He
not notice
admitted in our thyroid swelling. On examination, we explained him he is having the enlargement of the thyroid. Then he noticed.
Okay, so it is an additional finding to the next swelling.
Yes, ma'am.
Go ahead. We can go ahead with examination.
General examination. Patient examined in a well-lit room after proper informed consent. The patient is conscious, oriented, cooperative, moderately built and nourished, afebrile, pulse rate 88 beats per minute, respiratory rate 22 per minute, BP 110/70 mmHg. No pallor, no icterus, no pedal edema, no clubbing, no.
Go ahead.
No cyanosis, no generalized lymphadenopathy. Then examination of the neck. Inspection. A horizontally oval swelling of size 5×3 cm present in the left side of the neck, about 2 cm below the angle of the mandible, over the anterior border of the sternocleidomastoid mastoid muscle. All borders are clearly visible. Surface appears smooth. The swelling moves with deglutition and does not move with protrusion of tongue. The plane of the swelling is deep to the deep fascia. The skin over the swelling appears normal. No visible pulsations. In this, I am explaining the left side, the lateral neck swelling, sir.
You go ahead. Finish your presentation.
So this is the lateral neck swelling. This swelling is moving with deglutition. Swelling in thyroid region of size 4 × 3 cm, surface smooth, moves with deglutition, does not move with protrusion of tongue, skin over the swelling normal, lower border visible, no other visible swellings in the neck. Palpation. A horizontally oval swelling of size 5 × 3 cm present in the left side of the neck, about 2 cm below the angle of mandible, over the anterior border of the sternocleidomastoid muscle. The inferior border is found to be in continuation with the left lobe of thyroid and palpation. Surface appears smooth. Swelling moves with deglutition and does not move with protrusion of tongue. The consistency of the swelling is firm. There is no local rise of temperature. It is not tender. No palpable thrill. The swelling in the thyroid region of size 6 × 5 cm, surface irregular, moves with deglutition, does not move with protrusion of tongue, skin over the swelling normal, lower border visible, and the consistency is firm. The left lobe of this swelling is in continuation with the left neck swelling. No other palpable swellings in the neck. Then auscultation, no audible bruit over the swellings, percussion over the sternum, no retrosternal extension. Then examination of oral cavity, lips normal, poor oral hygiene, dental caries present, few loose tooth present, soft palate, uvula, tongue normal. Then systemic examination, abdominal examination, inspection, abdomen shape normal, umbilicus in midline, no visible pulsations or peristalsis, previous pictile scar in the mid-axillary line below the costal margin, no active discharge from the, no bilateral hernial orifices normal, bilateral renal angle normal, external genitalia normal. Palpation, there is no local rise of temperature or tenderness. Liver was palpable about 3 cm below the right costal margin in the mid-clavicular line. It's firm in consistency, surface appears irregular. Percussion, no free fluid. Upper border of the liver dullness is present in the right fifth intercostal space. Liver span is 16 cm. In auscultation, vowel sounds present, normal. Rectal examination normal. Other system examination, CVS RS normal. Summary. A 45-year-old male patient presented with a complaint of swelling in the left side of neck for the past 3 months, insidious in onset, gradual in progression, with the swelling noticed in the thyroid region for the past 10 days. Both the neck swellings moves with deglutition, with no features of hypo or hyperthyroidism, no associated pressure symptoms. Diagnosis. A case of multinodular goiter presenting as a lateral neck swelling with no toxic or pressure symptoms.
Go to your first slide of examination.
Okay.
So you've written that the swelling does not move with protrusion of the tongue. What were you expecting in this case?
This swelling, normally a thyroid swelling moves with protrusion of, moves with deglutition. Thyroglossal cyst will move with protrusion of tongue. The swelling is moving with deglutition.
We expect a lateral swelling of the neck to be a thyroglossal cyst. And at what age do we expect that?
Ma'am?
What age is thyroglossal cyst common? What will be the age of the patient presenting with thyroglossal?
In young
Yes.
In
Yes.
engage only,
And a
sir.
lateral swelling is very less likely to be a thyroglossal cyst.
Right. I mean, there's no way a thyroglossal cyst will be on the liquor. We are not actually. I'm not still sure. There's a single swelling. Is there a swelling in the midline in the thyroid region, or there's still just a lateral swelling? Even by examination, I'm not very clear about it.
Sir, in inspection, it appears as a separate swelling, sir. But in palpation, we can see some continuation with the thyroid, sir, for the lateral swelling, sir.
No,
So
you
the
mean to say
thyroid
that
is palpable.
Sir?
Is the thyroid palpable?
Yes, sir.
Okay.
it's a normal size thyroid, or the thyroid is enlarged?
Thyroid is also enlarged, sir.
So what is the description of the thyroid swelling? Come to your next slide on the palpation.
Okay. Sir,
This is
Now you're saying
inspection.
there's a swelling in the thyroid region on palpation.
yes, sir.
Now, so there
This
are
is
two swellings.
inspection,
There's
sir.
one swelling of 4 centimeters in the midline, and there's another swelling on the lateral side of the neck.
5
Yes,
centimeters.
yes, sir.
Okay. Okay. Right, go on.
So what is the extent of this thyroid swelling? Is it in the midline, on the left side, both in the right and the left and the midline everywhere? What is this 4 into 3 centimeter? Where it is located?
It is located predominantly
You
in the
said
right
that
lobe,
it is
sir.
in the lateral neck swelling. So I mean it is in the left lobe of the thyroid, arising from the left lobe.
Yes, sir. That lateral swelling is in the left lobe, sir. This swelling is predominantly in the right lobe with isthmus, sir.
So make it clear that you're palpating the left lobe of the thyroid, which is there's a swelling in the left lobe of the thyroid 4 centimeters. You're saying swelling in the thyroid region. We're still not clear where is this swelling. Does not move on protrusion of tongue, all that kind of moves with deglutition, right?
Okay,
So
sir.
there are two swellings now. There's
It
one on the
involves
lateral right, and there's one swelling on the left
both the
lobe.
lobes or only one lobe?
Sir, involves both the lobes, sir. Thyroid, sir.
Both the lobes. 4 centimeter will involve both the lobes. I mean, and that
Sir,
too, which is
in inspection,
is-
it appears like 4 cross 3 centimeters, sir.
this
In
slide is for
palpation,
inspection or palpation? This slide.
it's for inspection, sir. Inspection, sir.
Okay, let's go to palpation.
So you have got a very good video and picture also. Can you show on inspection on the photograph where is this swelling of the thyroid?
In the
If it is visible on
it's not.
inspection, where it is?
Yeah, okay, sir.
On the patient's picture photograph.
Yes.
Where is the thyroid swelling?
Sir, in the right lobe, sir.
Can you
Right lobe.
enlarge? Okay, we'll take your word for it. We'll take your word for it. I mean, we got to imagine really hard to be sure. Okay, I think there's some fullness there on the right. The sternum
Right
mastoid is
also.
slightly. What is trail sign?
Sir?
What is trail sign? What is trail sign?
Trail sign, in case of tracheal deviation, there will sternocuda will be prominent, sir, in the side of deviation.
Which head of the sternocleidomastoid master?
Clavic,
Sternal
sternal head, sir. Sternal head of
Right.
the sternocleidomastoid, sir.
So let's go to your inspection again now. Back to your inspection. No, your slide for inspection. Yes. So you say that. So on inspection, you're not seeing the right thyroid, right enlargement of the right lobe of the thyroid.
I can see it, sir, but in palpation, it appears to be larger, sir.
So why aren't you describing it that there's a swelling on the right thyroid lobule on the inspection? Look, doctor. you got to tell us exactly that the whole of the thyroid is enlarged and there's a left cervical lymph node. By your history and examination, we are just going around in circles. You get me? You say, I can't see it it's not seen on inspection, then I can palpate it. Then you say there's a left lobe, then you say there's a right lobe also, right? So your palpation has to bring out very well that both the lobes of the thyroid are enlarged. And then you got to describe each of the swellings separately and the left cervical lymph node separately. Are there any lymph nodes on the right cervical region?
Sir? No, sir.
Are there any swellings in the right cervical region?
No, sir. No other node, no other
sir.
swelling palpable.
Okay. Sir, please. I think we should go to management.
How do you see in inspection that this swelling is deep to the deep fascia?
Yes, sir.
Yeah, you said the swelling is deep to the deep
deep to the deep fascia on inspection.
How did you do that?
Extending the neck, it becomes less prominent, sir. On putting deep fascia on stretching, it becomes less prominent. So I'm telling it is deep to deep fascia, sir.
I think it is very difficult to say, you know, to
Okay.
say in relation to the deep fascia. And that too only on inspection you are telling that, Jay. Where is the
It's not a
swelling?
very characteristic finding of a
triangle
thyroid.
involved?
Right.
The plane of the swelling in the thyroid can be said only because it is moving with deglutition, it is within the deep fascia. You cannot use the word it is deep to deep fascia, because by deep fascia we mean that the 3 layers are there. So it has to within the pretracheal fascia. There is anteriorly also there is a deep fascia, posteriorly also there is a deep fascia. The PG should never use the word it is a deep to deep fascia. It is only within the deep fascia, enclosed within the deep fascia. There is the only test which you can confirm is because it is moving with deglutition, not by stretching
And
the
of
neck.
course, right. And it moves below the sternomastoid. It will never go above the sternomastoid, right? Okay. So how do you manage? Sir, please, sir. Professor Srivastava, Brijita, please go on.
So I
Why
think
do you think it is a benign swelling? Why not it is a malignant nodule? Or it is a lymph node?
Huh?
Can it be a lateral aberrant thyroid, or it is just a lymph node, cervical node? And what do you say? It is a thyroid swelling.
The swelling moves with deglutition, sir. So
Okay.
I'm telling
Okay, Dr. Can it be a laryngosele?
Huh?
Can it be a laryngosele?
Laryngosele, the swelling is firm in consistency, sir. Then
Okay. Will that move with it?
Picture of laryngosele.
Huh?
Okay, what's the
typical feature?
What's a Zenker's diverticulum?
Zenker's diverticulum, it is a pulsant diverticulum between the two parts of the inferior constrictor, thyropharyngeus and greco-pharyngeus.
Okay. So what is the characteristic? Clinically, how will you know it's a Zenker's diverticulum or it's a laryngosele? How will you differentiate between it clinically?
What
will a laryngosele contain? What will a Zenker's diverticulum contain?
Sir, Zenker's diverticulum, it contains the food particles, sir. So the patient will present with halitosis.
Right. And what does a laryngosele contain?
Laryngosele, just
just air.
Yeah.
Some mucus and air. Okay. Can they move with on deglutition?
Yes, sir. It can.
No, they usually don't, because the opening is so small and the thing is so much larger. They come out from a very small opening, right? So they will not move much. They'll not. Right? Okay, go on.
So you have put only one diagnosis, that is that is a multinodular goiter. So so the sir's question was whether it can be a thyroid swelling plus a lymph node, which is very large. If it is a large lymph node which is adherent to the trachea, can it move? Is there a
Pretracheal nodes.
possibility?
Yes, ma'am. It can move, ma'am. Pretracheal pleuralgial
A
nodes can.
possibility that there is a thyroid nodule and a lymph node, which is the
Louder and tell why do you say it is separate and why do you say it is the same, or whatever you feel, whatever you are examined, and you should tell the finding confidently. What we want an answer from you.
whether the neck swelling and the lateral swelling are in continuity or not, or there was a plane in between them while examination.
Ma'am, in palpation, they appear to be in continuation, sir. In continuation, ma'am.
So you can tell that confidently. So you can say that it is not a separate.
Doesn't look like an appear, seems to be, or not. Your palpatory finding is finding. We want whether it is continuous or not. It is not an appear to be. That means you are in doubt.
And you have asked
a very straightforward question, madam.
And in the history, you have in the examination, you have seen whether the lower border is palpable or not. What did you see it for?
To look for any retrosternal extension of the thyroid.
Is there any other test? Is there any other test for retrosternal extension?
Clinical, we can do Pemberton sign.
What is Pemberton sign?
In case of retrosternal extension, the thoracic inlet will be narrowed. When we ask the patient to raise his arms overhead close to the ears, there will be due to the narrowing of the thoracic inlet, there will be congestion of the face and neck.
So there will be facial plethora.
Facial, okay. Okay. Congestion.
Is it required to do to look for the lower border retrosternal extension in a lateral neck swelling, which your patient is having, and that too it's too high? And it should be somewhere in the midline. Sternum is in the midline, so it has to be midline, reaching up to the sternal suprasternal notch. Okay, thyroid is something which it's not very clear, but we take what you say, that there is a thyroid swelling and there is a lateral neck swelling which appears to be an extension of the thyroid swelling or a lymph node which is in the paratracheal location. But in contrast to what you presented in your history, your abdominal is now, there is only a scar without any discharge. And in the diagnosis also, you have completely forgotten whatever the history was there of the discharging sinus, pus and everything. So how come this? I mean, based on the history, your finding may be something different, but you cannot totally ignore that and keep a diagnosis of multinodular goiter. So would you like to revise it? If, and then you have to say two pathologies, multinodular goiter with a healed liver abscess, you say. Because the history is of 3 months of neck swelling and 3 months history of only an abscess, and for past 1 month it was a purulent or a pus draining sinus, and on examination it is only a scar without any discharge. So you cannot omit that.
Okay, sir.
Would you like to revise it? Because then only you will plan your investigation. See, the whole idea of clinical presentation of your history and examination is just to cut short your possibilities, what you can have. and so that you can investigate, you can plan your investigation. It is not that you do a head-to-toe investigation and then make the diagnosis. That is not at all possible. So you have to keep something. With what history you have given, you have to keep it in the final diagnosis also. Final means your diagnosis after examination. So what revision you would like to have?
Mm. In healed, healed liver abscess.
Healed liver abscess. Okay, you keep healed liver abscess, multinodular goiter with healed liver abscess. But something which, as sir has already said, that you should make some possibility with, a common etiology with both these presentation. Even the time frame is also same. Had it been say 6 months, 1 years back, then you might have omitted it. But because the total duration is 3 months for both the histories, I know it is quite a tricky case. It's not a very straight case, and I really compliment you for taking such a challenging case.
What do you mean by metastatic abscess?
Yes, keep a possibility like this.
Okay.
How do you differentiate ectopic thyroid from this? Suppose there is a swelling like this in a lateral abdomen, you are not able to see the thyroid at all. There was only one swelling. What is it? What do you mean by ectopic thyroid?
Thyroid gland present in regions other than the normal patient, sir.
What are the common areas?
It can be in lingual thyroid.
It's only in lingual. That's all. The node and the ectopic thyroid. Is there any difference? You can make it out. Other than it moves with deglutition. Normally, because ectopic thyroid will say within the IJV, intrajugular vein, medial to that. Usually the nodes will be always lateral.
Okay.
And thyroclastal cyst can occur. You can normally the thyroclastal cyst is not in the midline. It usually goes a little more deviated to the left side. So you will see the thyroclastal cyst. You can see on the left side of the, but it will have some close, but not exactly in the midline. It will be there. It is more towards the left. It will be there.
Okay.
With the diagnosis that you have given, multinodular goiter, how do you explain the weight loss? Is what might be the possibility in this patient?
With clinically euthyroid status, as you have said.
Yes, sir. It can be a thyroid malignancy, short duration, significant loss of weight.
Could we move to the management? So,
copious amount of discharge is there. The discharge is mostly it is nitrogenous or proteinous. So the more you lose the pus, it is all you are losing the more protein. There is more possibility that is a weight loss will be also there. It need not be purely based because of your appetite. So here, though it is MNG, maybe the weight loss maybe due to the liver abscess and the pus discharge, because the liver is damaged, the metabolism will be also damaged. You need to expect that why you are expecting a weight loss here. Yes.
Okay.
So you incidentally detected this patient to have a thyroid swelling in the ward. So how will you go about with it next? What will be your next step?
Then I'll go with the imaging.
What
Mm.
imaging will you do?
Initially, I will do USG neck.
Yes. What will you see in the ultrasound?
I'll look for a um, whether the both swellings are the same or not. Look for what the
You will see the origin of the swellings. Where
swelling
are they originating from? Then you will see whether they are solid or cystic.
cystic
Yes,
component.
yes, thyroids. So assuming that these swellings are from thyroid, what all will you see? What is the thyroid score? I mean, what all do you see?
Echogenicity, whether it is hypoechoic or hyperechoic, cystic or solid components are there, whether any calcifications are present or not. Then I look for any node, whether any small nodules, non-palpable nodules in USG. Then I look for any nodes in the neck.
So in this patient, what was your finding?
In USG, enlargement of the thyroid with the microcalcifications present. Then with multiple
Were there
nodules, largest largest in the left side, ma'am.
solid or cystic or mixed?
It's more towards solid, ma'am.
Okay, and what was the thyroid score which was given?
Thyroids, it's given.
Have you
Okay, suppose
got a thyroid score or not?
Sir?
Have you got a score?
have they given a score in the report?
No, they haven't mentioned the score, ma'am.
Okay, assuming they have written as thyroid 3. So what will you do next?
Thyroid 3, ATP of undetermined significance are and then I will do repeat FNAC.
If they have written that there are multiple nodules in the thyroid which are benign, but there is one nodule which is suspicious, then will
USG
you
guided
go about?
FNAC.
Okay, and if all nodules are benign, will you go for an FNAC?
All nodules are benign. Thyroid 3 size thyroid 3 means it is
No,
mildly
all nodules are
suspicious.
benign. It's thyroids 2. All nodules are cystic or not
No need,
suspicious.
no need for
In this,
FNAC, ma'am.
the large thyroid swelling, is there any need to go for FNAC?
No, ma'am.
There's no need to go for FNAC. Only if there is a suspicious nodule, then we will go for FNAC. Correct. So what is your next step?
Imaging, then FNAC.
You answer continuously. What is asking question? Don't wait.
I
Will you do a thyroid
image.
scan? Is there any indication for thyroid scan in this patient?
No, ma'am. Thyroid scan. No.
When do we do a thyroid scan?
Thyroid scan is mainly for in case of toxic thyroid. We to look for the heart nodule.
It's an
Okay, so in this
indication of
patient,
thyroid scan. What all are the indications for thyroid scan?
Indications. Toxic goiter is in.
Graves' disease you'll do.
Yes. Graves' disease, there will be diffuse uptake.
Not detected.
Was the FNAC done in this patient?
Yes, sir. Done, sir.
Okay. FNAC or FNAB?
FNAC, sir.
FNAC.
Yes.
Okay. What was the result of that?
It's a Bethesda category 2 they have given, sir.
Pardon?
Colloid. Sir, they have given it as a colloid nodule category 2. We have taken it from the lateral neck swelling, sir.
Yes. What was the result of that?
Bethesda 2, sir. It's a benign colloid nodule they have given it.
No, the lateral neck swelling was a lymph node on ultrasound.
No, sir. It's given as a
It was a
continuation, sir.
continuation of the thyroid itself.
Yes, sir.
Okay.
And what about the abdomen, ultrasound abdomen? Was it done?
Sir?
Ultrasound
Yes,
of the
sir.
abdomen.
Yes, sir.
Was the
It's done,
ultrasound
sir.
abdomen done in this patient?
Yes, sir. Done, sir.
So look, you have to mention that sorry, that you'll do an ultrasound of the neck and the abdomen. You've got to. She's come with this sinus in the abdominal wall. You've discovered the thyroid swelling, isn't it? So obviously
Yes,
she's
sir.
not bothered about the thyroid, or he's not bothered about the thyroid swelling. He's bothered about the liver pathology. That also has to be addressed,
Okay, sir.
isn't it? And that's the primary
Yes, sir.
concern,
Also
right?
in this
So what
patient,
about the
one of the very important finding on the examination was that the lateral swelling was moving with deglutition. A lateral
Yes, sir.
lymph node will never move with the deglutition. Only if it is a delphic lymph node is there, pretracheal lymph node is there, that can move with deglutition. The lateral will never move with the deglutition. And probably that is the finding. You can say that it is the same swelling from the thyroid. Okay, it is not the different swelling, it is the same swelling, but it is bulging from one side more. So it's like a lobulated swelling coming out of that.
Okay.
Yeah. What is quadruple testing? Madhvi, what is quadruple testing?
For it is done for thyroid swelling, sir. The
Yes.
first first clinical examination, then histopathology, then imaging, and genetic testing, sir.
Genetic testing.
There is always a
Thyroid
confusion in this quadruple testing. Some people say that is the clinical examination, thyroid function test, radiology, and cytology.
Histopathology.
Some say no, thyroid function test is a inbuilt part of that. So it is the clinical examination, radiology, cytology, and the molecular testing here. Okay.
Yes.
So both the answers probably are correct. Right?
What is the next step?
So what?
Will you go
Yeah.
ahead?
Mm. Uh, mm, Sorry. Mm,
Will you plan for surgery or not?
mm, In F, the patient in FNAC, it's given us only as a Bethesda 2. If the patient is having any symptoms, I can go for surgery. Huh?
Talk about your patient. As well as large swelling.
The patient is not having symptoms.
Okay, I think we need to close because this case was mainly presented to just to as Khanna sir has said to point out that somebody who is coming with a lateral swelling, when it moves with deglutition, it can be only thyroid. So just to demonstrate. But in fact, the patient has absconded because they were too much giving importance to the thyroid and forgetting about the abdominal sinus and the abscess. Patient has ran away from the hospital. But they have not done any procedure for
Right.
the patient.
This is what exactly I've been trying to say. The patients come with a discharging sinus. That has to be addressed primarily. Your finding is not important to the patient. You get
Okay,
me?
sir.
Right.
Okay, sir.
You can't go around, I found a swelling in the neck, so I'm going to treat that. I'm not going to think about your abdominal sinus. No, that's wrong.
Okay, sir.
Kanayvel sir, I think we can
Somebody-
close and go for the next case at this case.
Somebody has asked about the weight loss in this patient. I think that you can explain by the liver problem which is there. Okay. So rather than going for the thyroid here, because that is her main complaint, this patient main complaint is the liver problem which is there. So the weight loss can be because of that.
I think, sir, this was an interesting case. If given a chance and making the diagnosis, I think we should discuss this as well along with the presentation. So first possibility, I mean, if I'm allowed to speak, sir, then keeping one etiology for both the swellings, then clinically tuberculosis. Second will be some malignancy which has been metastasis to the liver and wrongly has been dealt with a percutaneous drainage and got secondarily infected. And third may be two pathology like a multinodular goiter or with a liver abscess. So any addition to this, or if any of the experts would like to give?
Yes, the tuberculoma of the liver can present this way.
Yeah. So it would be a miliary sort of tuberculosis, having
Yes.
all the everywhere, spleen, liver. They are
Yeah.
not very big abscess cavities, but looking in the
Biliary
physical.
It's very rare. Tuberculoma of the liver or tuberculosis of the liver is rare. Presenting it as an abscess, but it can.
abscess in the thyroid is much more rare.
Oh, yeah. Probably the rarest area for an abscess.
Okay, well done. I think Madhav, very courageous to present this case. Very courageous.
Yes, yes.
You can unshare your.
Really difficult. Professor Khanna, I think I have some engagements, so if I'm allowed to leave this meeting.
Yeah, sure. Thank you, Vivek.
Okay, thank you, sir. Thank you so much.
Thank you for joining. I think Dr. Anurag Srivastava has joined now. In place of
Okay.
Vivek Srivastava, Dr. Anurag
Good
Srivastava.
Good evening, sir. Good evening.
And Professor Vivek,
Good evening, sir.
good evening.
Dr. Kanayvel, can we go to the next case?
Is the next? Sole Ramapriya. Please share your answer. You can introduce your unit, Chief, and then you can go ahead.
Yes, sir.
Make
Good
it full
evening, sir.
screen.
And
Can you make it full screen?
yes, sir, 1 minute.
Yeah,
Good
okay.
evening. Good evening, sir. Myself, Dr. Sole Ramapriya, General Surgery PG from Government Roypet Hospital, Kilpak Medical College. My chief is Dr. Vijayalakshmi ma'am. The case today is a CA breast case. The patient is a 60-year-old female, Mrs. Shanti, who is a housewife residing in Injambakam, came to the OP with complaints of lump in the right breast for the past 4 years and lump in the left breast for past 3 years, with complaints of pain for past 6 months and nipple discharge on the right side for past 6 months. History of present illness. Patient was apparently normal 4 years back. Patient then noticed right breast swelling, a lump for the past 4 years, which was insidious in onset, slowly progressive to attain the present size. And patient also had noticed a lump in the left breast for the past 3 years, which was also insidious in onset, slowly progressive, and rapidly increased in the size for the past 6 months. Patient gives a history of nipple discharge for the past 6 months from the right breast, which is scanty, watery, red in color, staining her clothes, no offensive odor. History of pain for the past 6 months, occasionally. No history of nipple retraction, no history of fever, no history of trauma, no history of significant loss of weight, and no history of loss of appetite. No history of swelling elsewhere in the body, and no history suggestive of symptoms suggestive of metastasis to lungs, liver, or brain and bone. Past history. Patient had a similar lump in the right breast 8 years back, for which surgery has been done, and the histopathology report of the previous biopsy is a fibrocystic disease of the breast. Patient is a known diabetic and hypertensive on medical management for the past 10 years. Patient is a known hypothyroid on drugs. Patient is not a known case of pulmonary tuberculosis, bronchial asthma, or coronary artery disease and seizures. Personal history. She consumes mixed diet, regular bladder and bowel habits, adequate sleep, good appetite, no issue of any tobacco usage. Menstrual and obstetric history. Patient attained menarche at 19 years of age, irregular cycles since then and for every 3 to 4 months. Married at 21 years of age, non-consanguineous marriage, nulliparous woman, and history of infertility treatment for 3 years. Details not known. Attained menopause at 50 years of age. Family history. Patient gives a family history of breast cancer in her elder sister, who is also an nulliparous woman, was diagnosed with left breast cancer at 45 years of age, underwent surgery, and was not on regular follow-up. Later diagnosed with opposite breast cancer with metastasis and chorioendometrial cancer. She passed 10 years back. And also history of breast cancer in her younger sister, who was diagnosed at 48 years of age with a left breast cancer, surgery done 2 years back and alive. History of throat cancer in her father. Summary. Patient is a 60-year-old female, nulliparous, postmenopausal woman, presented with a lump in the both breast sequentially, which rapidly increased in the size on one side for the past 6 months with nipple discharge and occasional pain without any symptoms of distant metastasis. She has a history of hormonal therapy for the infertility and history of breast cancer in her first degree relative. I'll proceed with the examinations.
Oh, wait, you lost.
Yes.
we will be happy to hear from Rujita many questions.
Okay. So, from your history, what do you think these lumps are?
Carcinoma, ma'am.
What are the points in favor of cancer in this case?
Age more than 60 years. She's an nulliparous woman. History of infertility treatment. She would have taken hormonal or ovulation induction drugs. And family history, both our elder sister and younger sister has CA, and one had a bilateral breast CA with they said uterine surgery, so it may be endometrial CA also.
So it's a strong family history.
Yes, ma'am.
What else is in favor?
A blood stain nipple discharge.
Okay, can you go back to your first slide? You have said that pain for past 6 months. You have to tell
Yes, ma'am.
where was the pain?
It's not specific, ma'am. She was saying that it's occasional, only on doing hard work, she would feel some vague pain in the breast, like that only she said.
Okay, go to your next slide. So, nipple discharge was red, like you said.
Yes, ma'am.
Was it on expression or was it spontaneous?
While doing hard works, when she does strenuous activities, she while after that she may have that staining of the clothes, not active discharge. When she has a strenuous work, she'll have
It
staining
is
of
a
the clothes.
spontaneous discharge,
Yes,
not
ma'am.
on
Yes,
expression,
ma'am.
and
Yes,
unilateral
ma'am.
blood stain. So this is
Yes,
also
ma'am.
suspicious
Yes,
for
ma'am.
cancer.
Cans.
It is both the breast or the only one breast?
On right side, sir, not on the left side.
Suppose there is only one breast, one nipple is discharging. What else you look? What will the history you ask? Or what will be interested to say more in terms of significant? One you said, you just said it is a spontaneous, is more in
Yes, sir.
favor of it is serous and sanguineous. But one more, is it from the multiple duct or from the single duct?
Single duct.
So single, scanty, sanguineous, serous, or more significant. So that you should also focus on that when you are asking the issue. So here
Okay,
you are
sir.
not able to make up it is a spontaneous or expressive. When she is working, it is coming. Must be spontaneous then.
Yes, sir.
What are the risk factors in general for cancer breast? Which are the absolute factors and which are the modifiable factors?
Non-modified factors or age, sex, and age, sex, late menopause, early menarche, history of radiation exposure, and under modifiable,
So
obesity,
genetic factors are modifiable.
non-modifiable, sir.
Family history or
Family history, genetic factors.
and if there are any pre-malignant conditions like ADH,
Yes,
so they are not.
atypical ductal.
What are the modifiable factors?
Modifiable factors are obesity, tobacco usage, parity, breastfeeding, parity, first childbirth, age at first childbirth,
Any role of alcohol and smoking?
tobacco
HRT,
usage,
use of HRT,
hormone
replacement therapy.
hormone replacement therapy.
Yeah.
So in your patient, she has taken hormone therapy for how many years?
3 years, ma'am.
So it is significant only when it is taken for more than 10 years.
Yeah.
So in this case, it is not significant.
Is it a hormone replacement therapy is significant or even a hormone therapy is significant?
Hormone replacement therapy.
it was infertility means they are probably at the early age of her life.
Yes, sir.
And you said the menarche is only at the age of 19.
Yes, sir. I double checked with her. She said she had menarche at 19 years, and after 1 year, she got married at 21 years.
Right, there's a family history of breast cancer is there, like in
Yes,
your
sir.
patient.
Yes, sir.
What are the things you are going to ask in the family history?
The family history, not only for breast, for ovarian tumors or thyroid, male breast cancer, other
That is
colon,
one.
stomach,
Yes.
yes, colon,
What
stomach,
else?
bile duct,
What else you are going to ask?
Prostate in
age,
males.
prostate, pancreas.
Yeah, apart from the other cancers,
Yes, sir.
if the mother had a breast cancer,
Yes,
what are the things you are going to ask?
age at which she was diagnosed to have the cancer, either single side or bilateral, single tumor or multiple primaries.
These are two most important things, whether it
Yes.
occurred in the premenopausal or the postmenopausal, and whether it was unilateral or bilateral.
Bilateral.
Because if it is a premenopausal bilateral breast cancer is there is a highest chance, highest risk is there.
Yes.
What is the difference between a familiar breast cancer and a hereditary breast cancer?
Hereditary breast cancer, it runs in the family, but there will be a genetical mutation which runs from the parent to the child. In familiar, there may not be a common genetic mutation, but it runs in family due to environmental and same lifestyle factors.
Now,
In
can you tell
genetic,
that? Yeah, please carry on.
There will be gene mutation which will be transmitted from the parent to the children. In familial, there won't be any specific gene mutation, maybe because of environmental and lifestyle factors which runs in the same family. They'll have.
Which are the hereditary cancers which you are suspecting in this patient?
In BRCA 1 and 2 or 2.
Why 1? Why not 2? Because she has bilateral cancer. Which cancer is more common, bilateral or unilateral? If you have
in
BRCA1 or BRCA2,
BRCA1 bilateral is common.
Common. What about what is lobular carcinoma? What is lobular carcinoma of the breast? And what is rule of 10 for lobular cancer? Do you know rule of 10 for lobular cancer?
No, sir.
10% are lobular of all the cancers, 10% bilateral, 10% multicentric. If you have bilateral cancer, think of lobular.
Oh.
Right. And out of BRCA 1 and 2, which is more common?
1.
Incidence?
BRCA
1. 1. Yeah. So 1 is associated with ER positive cancer or ER negative cancer?
Negative. Mostly triple negative.
More commonly.
More commonly triple negative.
Mostly triple negative. And BRCA2? BRCA2? Mostly with positive. ER positive.
Yeah, receptor stated positive.
More commonly ER positive.
Positive.
Yeah. And lobular is usually ER positive. Lobular cancer is usually ER positive.
ER positive.
So if you have bilateral cancer, think of lobular. Yeah. Lobular mostly bilateral. Yes. 10% are bilateral. So with 3 members of the family, what has gone wrong in the family which has led to death of sister and occurrence of cancer in the 2 other sisters? What should have been done in an ideal state?
The family has to be screened previously for genetical diseases, and early screening for early detection of the disease too has to be done, so that she won't present later.
So they are, suppose you think they are screened, they found out
to
it's a
call it
BRCA1
or something else.
Sir?
Sorry. Yeah.
they found out the BRCA1
Will
is
you call it
positive.
screening or surveillance? Surveillance for cancer. Because you
Surveillance.
already know the high risk. So you will
Yes.
do surveillance for
Yes.
surveillance for cancer with what imaging method will you use for surveillance of genetically?
Mammogram. MRI mammograms.
Won't you do a genetic study? So, like,
Ma'am.
won't you do
Yes,
a genetic study?
Yes,
Such a strong family history. Genetic screening, won't you do?
Yes, genetic screening has to be done.
So if you have found out she is BRCA1 positive, suppose you are done as doing a genetic, what you will do?
Patient can be planned for prophylactic mastectomy.
Straight away.
Sir?
Straight away, if it is found that, yes, one you will go for a prophylactic mastectomy.
Or risk reducing interventions can be done.
What are the risk reducing interventions?
She can be given if the patient has completed a family ovarectomy can be done, or ovary ablation by drugs can be done.
Excuse me, it is not prophylactic mastectomy. The term is risk-reducing mastectomy because the bilateral mastectomy only reduces the risk to about 90%. 10% risk still prevails because of the small ducts left under the nipple or at the periphery of the breast. So call it bilateral risk-reducing mastectomy, not prophylactic. Okay.
Okay.
Yeah. And the correct surveillance for genetically induced cancer is MRI. And some people do MRI every, say, January, and 6 months later, digital mammography. So every 6 months, you do some imaging test, which is highly sensitive. So every January MRI, July, you perform bilateral to reduce the chance of interval cancers. So it is MRI is the most sensitive method for and some people say that you should not do too many mammograms because mammograms are based on X-rays, which is electromagnetic radiation, and it can induce cancer. So what is wrong with BRCA 1 or 2? You know, what is the basic defect? BRCA gene mutation. What is the defect?
In BRCA,
defect in the DNA repair.
Yes, sir.
It's a defect in the DNA repair. Okay, BRCA is a DNA repair gene. So if the repair gene is defective, DNA damaged by, say, radiation will not get repaired, and this will manifest as cancer. So there's a defect in the DNA repair. So you should not do too many X-rays, CT scans, and for these patients.
Yes, sir.
Besides bilateral risk-reducing,
sir, I was not able to hear, sir. Hello?
Any other surgery to reduce chance of ovarian cancer?
Sir, I was not able to
Bilateral, so done around 35 to 40 years of age.
Yes, sir.
At around 35 to 40 years of age, in BRCA1 or BRCA2 mutation carriers, you should also suggest or advise bilateral chance of ovarian cancer or Salping's cancer. Sometimes the cancer occurs from the fallopian tube, not from the ovary. So you should do bilateral salpingo-oophorectomy. Remove the ovaries as well as Salping's, that's fallopian tubes. Around 35 to 40 years, not very early. Otherwise, you'll induce premature menopause. So once they have completed family between 35 and 40, you should offer salpingo-oophorectomy.
Yes, okay, sir.
Thank you. Thank you.
You can go ahead with the general examination.
Yeah, please.
On general examination, patient is conscious, oriented, obese, well-built and nourished, ECOG score 0, afebrile, pulse rate is 82 per minute, BP is 130 per 80 millimeters of mercury measured in the right brachial in sitting posture, respiratory rate is 14 per minute, oxygen saturation is 98 in room air, no pallor, icterus, cyanosis, clubbing, bilateral pitting pedal edema or significant generalized lymphadenopathy. Local examination after
Did you say just put a word like obese? How come you come to the conclusion it is yes, obese?
So
You have to give the BMI.
Yes, you are giving a ECOG score, all that. So more of a scientific way of putting it, not just putting like obese. Okay, good.
okay. After obtaining consent from the patient was examined in a well-lit room, exposed up to the waist, with patient in sitting posture, arms by the side of the body. Both breast appears symmetrical in position, shape, and size. Scar of length 4 centimeter seen in the right breast at 9 o'clock position, extending laterally from the area. Sir?
Change the photo. No, change the photo because you should know.
Scar in the left breast at 11 o'clock position in the biopsy site and no visible mass seen. Skin over the breast, no dilated veins, dimpling or puckering seen. No nodules, ulcer or pudgy orange. Areola appears normal, symmetrical to the opposite side. Nipples, single, no retraction or active discharge seen. Arm and thorax appears normal. Supraclavicular fossa, no fullness seen. With arms raised above the head, no prominent swelling seen, no nipple retraction seen, no pudgy orange. Axilla, no visible swelling seen. Inframammary region appears normal. On leaning forward, both breasts falls equally on both sides. On contracting and relaxing the pectoralis major muscle, no prominent swelling could be seen. Palpation of the right breast, no local warmth or tenderness present. Single lump of size 3 cross 2 centimeter at 12 o'clock to 2 o'clock position, irregular in shape and surface, ill-defined margin, hard in consistency, moves along with the breast tissue, not fixed to the overlying skin or the underlying muscle and chest wall, no nipple discharge or retraction. On palpation of the left side, no local warmth or tenderness, single lump of size 4 cross 4 centimeter behind the nipple areola complex in the central quadrant, irregular shape and surface, ill-defined margin, hard in consistency, moves with the breast tissue, not fixed to the underlying muscle or chest wall and overlying skin, no nipple discharge. Examination of the axilla, right side no lymph nodes palpable, left side single lymph node of size 2 cross 1 centimeter in the central group, mobile and firm in consistency. Supraclavicular fossa, no nodes palpable on both sides. Percussion, it's resonant over the sternum. Other systemic examination, cardiovascular system, heart sounds I heard, no murmur. Respiratory system, normal vesicular birth sounds heard. CN, sir? Central nervous system, no neurological deficit. For abdomen, soft, no organomegaly or no free fluid. Spine and cranium, no bony tenderness. Pervaginal examination, os closed. Fornix is free and not tender. On distal rectal examination, tone is normal, no mass or deposit palpable. Summary, a 60-year-old nulliparous postmenopausal woman presented with a bilateral breast lump, which rapidly increased in size on one side for the past 6 months and nipple discharge and occasional pain with no symptoms of distant metastasis and positive breast cancer in the positive family history. On examination, patient had lump of 3 cross 2 centimeter in the upper inner quadrant in the right side and 4 cross 4 centimeter in the central quadrant on the left side with the axillary lymphadenopathy on the left side.
Excuse me.
Sir?
Yeah, very nice presentation. Can I make some comments?
Yes, sir.
First of all, the French word is peau d'orange. Don't say peau d'orange, right? French will be very angry. Correct pronunciation. Peau means skin, do means off, orange is orange. Orange peel appearance. Peau d'orange. Okay. Second, there are only 4 quadrants in the breast. Upper outer, upper inner, lower inner, lower outer. Okay. There is no central quadrant. Quadrant in English means 1/4. So out of after 4 quadrants, central area is called central region or retroareolar region. It is not central quadrant. Okay. But quadrant means 1/4. Third is when you requested the lady to raise her arms above the head, you should look for any dimpling or puckering of the skin or nipple retraction. Okay. On arm elevation, look for dimpling of the skin or puckering or nipple retraction. And 4 things, when you say bony tenderness, which particular bones did you test for tenderness? Which particular bones? What are common bone sites for metastasis? Common bones to have metastasis from breast cancer.
Ribs.
Where you should test the tenderness.
Spine.
Which spine? Spine.
Spinous process of the spine.
Lower 6 thoracic. Lower 6.
Sir, it's the voice is breaking, so I was not able to get the question.
Thoracic, T6 to T12, all lumbars, not a spine. You should say lower 6 thoracic, T6 to T12, all lumbar, sacrum, upper end of femur, upper end of humerus, sternum, and ribs. These are common sites.
Okay, sir.
Now, do you know what is ABCD rule for breast diagnosis? ABCD rule. Have you heard of ABCD rule for breast diagnosis? A stands for any asymmetry, right? When you're examining the lady, look for asymmetry. Asymmetry of the breast, asymmetry of the nipple areola, asymmetry of the axilla from an ulcer or bulge or prominent of the nipple areola, color of the breast. And D is for dimpling, D is for destruction of the skin, D is for deformity, right? So ABCD rule. You should read it in Indian Journal of Surgery. Okay?
Okay, sir.
And when you showed the first picture of inspection, hand should be on the waist, right? Not by the side of the breast. You hide the axilla. So you will miss some of the findings on inspection. Okay? So hand should be on the waist.
On the waist.
Hand should be on the waist. Okay? And read the detailed methodology of breast examination in Indian Journal of Surgery, an article called Clinical Breast Assessment. A very detailed methodology is given along with some videos. Or you can read the Bailey and Love, chapters 58, the breast, a new edition, 28th edition. In electronic edition, we have given the videos of how to examine the breast in detail. Okay, so read the breast chapter in new edition of Bailey and Love, volume 28. Okay. For detailed information.
Are you sure there was no asymmetry and
Thank you.
it is not retracted?
Sir, nipple retraction is not because of the scar. There was some like dog ear. It was there, sir.
What do you mean by nipple retraction?
Sir, inward movement of, sir, inward pulling of the nipple.
What is the normal direction of the nipple? Normal direction of the nipple?
It will be pointing out and lateral.
So what is happening in your patient? See, that doesn't need the inversion. You are not talking about inversion. There is it is going below the level of that. Here, when there is a change, it's happening. Why there you get a retraction in a malignancy?
Because of the infiltration of the lactiferous duct, sir. And contracture, the nipple
is infiltrated the lactiferous duct will block. Nothing will happen.
And contract, sir. It will contract, so it will pull the nipple inside.
Why it contracts? The tumor infiltration into the lactiferous duct will not contract. It is a periductal fibrosis, which is happening the periductal infiltration. What are the muscles of the nipple?
It is actually desmoplastic reaction.
Yeah.
So this looks like, I mean, obviously when we photo we are seeing it is there is a definitely the nipple is pulled inward, and when you are lifting the arm, there was obvious asymmetry seeing the upper limit, lower limit of the breast is different. So it is only a incidental, but you can have little more conscious look on that and make a comment on that.
Okay.
Also, you have written
And,
that the lump is ill-defined.
Ma'am?
So, you have written that the tumor is ill-defined.
Yes, ma'am.
Ill-defined. So, what are the ill-defined lumps that you can see in the breast? And if you're suspecting it to be a cancer, is it ill-defined or should it be well-defined?
Ill-defined, ma'am.
No.
What are the ill-defined lesions in the breast?
Cancer, carcinoma,
Cancer and normal tissue you cannot differentiate.
Yes, sir.
So
Cancer.
instead of having a tumor, you have a
Sir?
You have a tumor and a normal tissue. That is what
Yes,
we are
sir.
talking about, well defined. The border may be irregular, but you will have a well defined tumor.
So tumor has a well-defined margins. You will easily differentiate from the normal tissue. Ill-defined is something like an inflammation of the breast. If there is an abscess or inflammation, that is ill-defined. The borders are not defined properly. It merges with the breast tissue. Okay, so how you will proceed
Then,
with
Dr. Rajuta, we call it induration. Dr. Rajuta, then we call it induration. So there's no well-defined lump, discrete lump. It is induration. As in, you very rightly said, inflammation. Yeah.
How will you proceed?
Triple assessment, ma'am. First is triple assessment.
What is
so
your
first
provisional diagnosis? So what is your provisional diagnosis?
So diagnosis, synchronous.
Why not? It is a metastasis from this breast.
Maybe, sir.
But you are not thinking of that. You are very categorically saying it is a bilateral synchronous tumor.
So it's diagnosed in the same. She presented in the same time period, so I put this synchronous.
So tumor and metastasis will not come at the same time.
Can be.
It can also be benign on one side with a malignant on other side. She already has a history of a benign excision of a lump.
No, but it's a hard inconsistency on age, other family history, supportive history is there.
You will be careful thinking that it is cancer, but will you work up, like if you're doing a biopsy, will you biopsy both or will you biopsy only one side?
Both, ma'am.
Okay.
Both.
Yes.
Okay.
Before biopsy, what test you should do before biopsy?
Mammogram has to be done, sir. Digital mammogram.
And ultrasound, both. Because they are complementary to each other, you should combine ultrasound and mammography. And during ultrasound, you should request the radiologist comment on the axillary nodes and the major milk ducts. 3 things you should request: the lump in the breast, the major milk ducts, and the axillary nodes. Okay?
Yes, sir.
What is total in this criteria?
By mammography, will you be able to differentiate whether it is a primary or secondary?
Sir?
When you are doing a mammography, will you be able to differentiate whether it could be, can you make more points towards your diagnosis? It is a second primary, then it is a secondary. What is the difference in the mammography finding of a secondary lesion and a primary lesion?
There will be mass lesion, separate mass lesion.
In both, you will have a mass lesion. You will not have a speculation. The mass lesion with the speculation is a characteristic feature of a primary tumor.
Primary. Okay.
What is Chaudhary Mills criteria for bilateral breast cancer? So like
Answer: microcalcification. Cluster of microcalcification is also seen in primary, but not
Yes.
in secondary.
Yeah, sure. That's the two things. One is the microcalcification and the speculation. Both will not be there in the secondary.
That's right.
So, madam has asked you the Chaudhary criteria.
Yes.
So to say whether it is a second primary or it is a secondary, there are few like
histology will be different in two bilateral breast tumors. They are two different primary.
histology may differ, histological grading may differ.
Grading will differ, and the time at which it appears may differ. Okay.
So there is an axillary
What
lymph.
size needle would you use for biopsy? What size needle do you use for biopsy? Core needle biopsy. What size needle should you use?
18
And how many
gauge.
cores should you take?
18 gauge needle.
18. Preferably
Yes.
14 gauge needle. 14 gauge large needle core biopsy. You should not say true cut or sure cut. True cut, sure cut are trade names. You should say large needle core biopsy of 14 gauge. And you should take at least 5 cores. Some people say 6 cores. Because if you take less than 5, 4 or less, then chance of false negativity is high. There are a lot of studies have been done on this. If you take just 3 cores, and it should always be done under image guidance, preferably ultrasound guidance. Okay. So always image guided biopsy, 5 cores, 14 gauge needle. 3 things you should remember. Never do blind biopsy.
So you said there was an axillary lymph node which was palpable on examination. So
Yes,
you did a mammogram and there was a lymph node seen, and you also did an ultrasound. So how will you differentiate a benign from a malignant lymph node?
Usually a benign lymph node will be ovoid shape. In malignant, it will be round in shape. In malignancy, it will be taller than wider, and there will be loss of higher fatty hilum.
And anything about vascularity?
Increased vascularity and echoes may vary. If there is necrotic central necrosis, echogenicity may vary.
No, necrosis may or may not be there. That is not finding in favor of malignancy.
On a brain tumor, you can have a necrosis. Benign node, you can have a. So will you satisfied with the mammography alone in this case? Because the right side you don't have a node and left side you are having a node. Do you do any other investigation? And more so, your tumor was more on the inner side, no? One breast, the tumor is on the inner side.
Inner quarter.
So are you interested to see any other node?
Internal mammary nodes on the right side.
And again, you have put us your percus over the sternum for a mesh. Why you have percus over the sternum?
If there is internal node enlargement, there may be dullness over the sternum.
Over the sternum. The internal mammary node is
parasternal, by the lateral border of the sternum.
So why do you want to know whether this internal mammary node is involved or not?
Staging, TNM staging may vary. If the only if axillary node is there, it's T1. If internal mammary node is there, it will may have N2
N2?
N2A.
A.
N2. No, sir. N2.
B. And if the both are present,
N2A is mated axillary node, sir. B is internal mammary node in the absence of axillary. And 3A, it's
when both are present,
infraclavicular, sir.
When both axillary
Infraclavicular
node
with internal memory. And
internal memory node are present.
3B. N3B.
and supraclavicular node, supraclavicular. Again,
3C,
N3.
N3,
N3, right.
N3C.
So what are the changes in the AGCC edition of AGCC classification?
Sir,
AGCC 8 certifications compared to previous staging system. What are those changes? Do you know?
Either lobular carcinoma in situ
In AGCC 8th
high
edition, it is not just anatomical staging. Very good.
Lobular carcinoma in situ is a high risk benign condition, not a malignant lesion. And in TNM staging, if there is multiple primary, M prefix has to be used. And if post neoadjuvant chemotherapy, Y prefix has to be used. And
good, very good. So you add response to therapy.
Complete response.
The new
Sir?
Is it lobular carcinoma in situ is a benign lesion?
And ER, HER, KI67. This is also included in the staging.
So you said lobular carcinoma in situ is a benign lesion.
It is now considered as a non
high risk benign lesion, it is not malignant.
Not a malignant
in
precursor of, it is not a malignant precursor of lobular carcinoma.
It is considered a risk factor.
Lobular carcinoma in situ will also produce ductal carcinoma.
Yes.
So it cannot be taken purely as a benign lesion. It's not a precursor of the your lobular carcinoma. But Rituja, what is your opinion on that?
Yes, sir.
Yeah, it is a high risk lesion.
High risk lesion can
in the 8th edition, LCIS has been considered as a high risk lesion. It is not. In fact, the new term is lobular neoplasia. They don't say cancer. So they have removed the term cancer. They say lobular neoplastic lesion. Lobular neoplastic lesion. So they don't say cancer. Say lobular neoplastic lesion. And it is being cancer in future is 10 times higher if lady has lobular lesion compared to a normal person. So relative risk is very high, 10 or more, and therefore it is not considered as a cancer itself. So what else do you add?
Your voice is often breaking.
Scoring. Do you know what is oncotype DX?
Hello,
Hello?
Sir?
What
Not
is
able to get you, sir.
oncotype DX?
It's a
what is
genome,
oncotype DX?
It's a genome, sir. Hello? Genome testing,
Yes.
sir, for a 21 genome, they'll test in oncotype DX to assess risk of recurrence in the patient who is undergoing in early breast cancer. in an early breast cancer patient, it's used to assess the risk of recurrence in the patient. It uses 21 genomes in
How do you send the
Darnington
specimen
stage.
for assessment?
Sir?
How do you send the specimen for assessment? Is it a frozen section or you should go into the formalin?
Frozen sections. I don't no idea.
Type is in a formalin. Sorry, frozen section.
Frozen. Yes. And regarding that, they'll categorize a patient into low risk, intermediate risk, and high risk, and we can plan for adjuvant chemotherapy if the patient has high risk, and there's no need for chemotherapy in patients with low risk, and hormonal therapy can be given if there is ERPR positive status.
Yeah. So oncotype DX is arranged for ER positive, node negative,
Yes, sir. ER
1
positive patient.
centimeter or less tumor. More than 1 centimeter, you will have to give chemotherapy. Node positive, you have to, ER negative, you have to give chemotherapy. Sentinel node negative and less than 1 centimeter. Okay. Because it costs a lot. It costs around 4 lakh rupees in India. Because you have to send the slides to one lab in California for doing this testing. How will you manage this lady? How will you manage this lady? Yeah.
So
No, triple SM has been you have
sir, if the patient after immunohistochemistry report, if the receptor status is positive, we can proceed with a bilateral
carcinoma in situ grade 3 ER positive.
Okay, sir.
This is a common mistake residents do in exam. You should say that I will discuss the management in the multidisciplinary tumor board. Right?
Okay.
Never say I will do this, I will do that. You should I will discuss the management plan in the multidisciplinary tumor board, where we have radiation oncologist, medical oncologist, pathologist, radiologist, breast care nurse, and maybe patient's relative, spouse, and plastic surgeon. Then we'll discuss the plan and we'll offer her mastectomy or breast conservation depending on the decision. Okay. Never say I will do this, I will that. Okay. Always say I will offer breast conservation or mastectomy depending on the decision of the MDT.
Okay.
What is the stage of the receiver?
Ma'am,
what is the stage?
On right side is T2N0MX, ma'am, stage 2A, and on left side T2N1MX, stage 2B, ma'am.
So both are early breast carcinomas.
Yes, sir.
So how you are going to proceed with early breast carcinoma?
So we have to discuss in the multidisciplinary team, sir, and
what is your view? The multidisciplinary team, you need to propose some procedure. What you are going to propose?
Sir, if receptor status we have to see, sir. If ERPR positive, we can go for either a modified radical mastectomy or breast conservation surgery. But this patient has high risk with the family history and bilateral disease, so we can proceed.
You will think of breast conservative surgery? Yeah?
No, sir.
Yeah. Why?
Because of high risk, sir. High risk.
High risk.
Patient.
It is because you are expecting multicentricity here.
Yes, sir.
Tumor, we are having a bilateral tumor. We are looking that multicentricity is one of the commonest way it can.
So I'll proceed with the bilateral modified radical mastectomy, followed by adjuvant therapy, sir.
So right side, do you have a node?
No, sir.
So without node, you are going to do the axial dissection?
We have to proceed with the sentinel node, lymph node biopsy, sir.
You have said it's a modified radical mastectomy that include axillary dissection. So I
Yes.
do not have a node in the axilla.
So right side, I will do a modified radical mastectomy and sentinel lymph node biopsy. If the node becomes positive, we can proceed with axillary clearance, and negative, we can
When you say
stop.
modified radical mastectomy, that includes axillary dissection.
Axillary node dissection. Yes.
So it is better you talk what you are going to do the breast, what you are going to do the axilla, what you are going to do for the systemic management.
So then right side, I'll proceed with a simple mastectomy followed by sentinel lymph node biopsy. And if positive, we'll go for axillary clearance. And if negative,
Again, you are wrong. Again, you are wrong. Are you going to do the sentinel lymph node sentinel biopsy after doing a mastectomy?
sir,
You
in
said
the
simple
same
mastectomy
procedure.
followed by
No, sir. Node biopsy has to be done before. Means peritumorally, we have to infiltrate the drug, the technetium labeled sulfur colloid, and we had to proceed with the sentinel node biopsy.
Suppose on the left side you are doing a sentinel node. See, and this node, which we are obviously seeing a node, it is not taking
Yes,
up the. It's not taking up. So, what are the possibilities? Do you think it is a benign node if it is just not taking up?
No, sir. We clinically palpable axillary lymph node. We can proceed with axillary dissection.
The node is completely replaced by the metastatic tissue. It may not take up the. Just because it is not taking up, you cannot rule out that. When the node, the normal node has been replaced totally with the metastatic cell, it will not take it up.
Okay.
Yeah, this is the reason why during sentinel node biopsy, you should remove any blue node, any hot node on isotope, and any palpable node should also be removed, right? So sentinel node biopsy includes hot, blue, palpable, or fluorescent node. So palpable node must be removed, but as sir said, they can be replaced by the tumor cells and therefore will not take up any dye. So all palpable nodes must be removed during sentinel node biopsy. Suppose sentinel node biopsy result shows one node involved by micrometastasis. One node by micrometastasis. Do you know what is micrometastasis in sentinel node?
Less than 0.1 millimeters.
0.222.
0.2.
No,
0.2 or 200.
0.2 to 2 is, and less than 0.2 is isolated tumor cells. Okay. So 0.2 to 2 mm is called micrometastasis. For micrometastasis, you do not do X-ray dissection. Okay. You do X-ray dissection only when more than two nodes are involved by macrometastasis.
Yes.
Macro means more than 2 mm
millimeters.
in the node. Okay. And can you name the trial which has shown all these findings? Very important, very world famous trial. It is widely quoted in all the breast meetings. It is attached to name of who is father of sentinel node biopsy, Dr. Armando Giuliano. Do you know Giuliano?
Yes.
Armando Giuliano in Santa Monica in California. He is considered the father of sentinel node biopsy. And Giuliano performed the trial Z0011, Z11 trial in America. And they included 891 patients, half randomized for sentinel node biopsy, and then observation of the axilla. So up to 2 macrometastasis nodes were taken, and they were offered either full X-ray dissection or just observing the axilla. And they have shown that the long term, even at 10 years, 12 years follow-up, last paper was published in 2016, and they have shown that the long-term outcome in terms of local recurrence, axillary recurrence, and survival all are similar, whether you do only observation of the axilla or you perform ALND, axillary node dissection. So up to 2 macrometastasis, you can just observe the axilla, give a radiotherapy, chemotherapy, or other therapies, right? But you need not dissect the full axilla. You should dissect the axilla only when more than 2 macrometastatic nodes are involved. Okay? So you should remember this. Dr. Rijita, what is the plan of axillary node sampling in Tata Memorial Hospital, where you are currently working as faculty?
Yes, sir. No.
How do you
Sir,
address the axilla in Tata Memorial Hospital?
so, in any non-palpable or non-suspicious nodes in axilla, and we don't give any dye or any, nothing is injected, but sampling is taken from strict boundaries which are bounded superiorly by the intercostobrachial nerve and inferiorly by the angular vein, and the margin is next to the chest wall up to the lateral border of the LD. So the principle is that the arm lymph nodes which may affect lymphedema in future, these are avoided in this sampling which is taken. So there's a restricted patch of tissue which is removed along with lymph nodes. Around 5 to 6 lymph nodes are actually achieved from this dissection. And then we can send it for frozen section.
So this is anatomical. So yeah, so this is anatomical axillary sampling as described by Professor Rajan Badwe and Dr. Vani Parmar in Tata Memorial Hospital. And they have wide experience on this. So if you do not, any center does not have the tracers for sentinel node biopsy or does not know the technique of sentinel node biopsy, then anatomical axillary sampling as described by Professor Rajan Badwe and Dr. Vani should be done. Very good. Thank you.
But axillary sampling, if you are not getting the node in the level 1, suppose you are not getting at least a minimum 4 nodes, will you go to level 2 or you'll,
So
in case you are not able to get the 4 nodes?
If we are not getting below the intercostobrachial, we can go a little further up, but then the arm nodes are below the axillary vein, but above the intercostobrachial.
Yeah. So there is still level 1. So still it is level 1, not level 2.
So how do you?
And again, it is important to appreciate if you have done full axillary dissection, then you never irradiate the axilla. If full axillary dissection has been done and 10 or more nodes have been sampled, then which is the definition of full axillary clearance. At least 10 nodes should be harvested, and then you should avoid giving radiotherapy to that axilla. Otherwise, the risk of lymphedema is very high.
That's true.
If patient in this case is insisting on breast conservation, will you offer her?
We have to explain, and if she is complained to follow up regularly, and she's willing for post-surgery RT, and we can train her. But it's the risk has to be explained in prior.
Yes.
What risk you are going to explain?
Sir?
What risk you are going to explain?
There may be local recurrence or
No, that is not the reason.
New primary, new
multi-tumor.
Due to multicentricity, she may have another.
Why? If there is no multicentricity, you can obviously go for that.
Yeah. So you should always do MRI scan with contrast to rule out multicentricity in these genetic risk carriers. So with family history, you must do MRI to rule out multicentricity if lady insists on breast conservation. What is difference between multifocal and multicentric tumor? What is multifocal? What is multicentric?
In multifocal, there will be it will be confined to one quadrant of the breast. In multicentric, the lesions will be in different quadrants of the breast.
Or
So
they are
God did not create quadrants. See, God did not. If you open the breast tissue and see in the dissection hall, God did not make four walls like four walls of the room, right? Quadrant is a totally artificial
So
concept,
if two
right? It is
tumors,
a continuous tissue.
distance
So you
between
should say if two tumor foci are located within 4
less
centimeter
than 5,
distance,
5 cm.
less than 4 centimeter, most people say 4 centimeter apart,
Yes.
then it is considered multifocal. If
Multifocal.
two tumor deposits are more than 4 centimeter apart or in diagonally opposite areas, opposite quadrants, then we should call it
Multicentric.
multicentric, right? In multifocal, you can still do wider lumpectomy, wider breast conservation can still be done. But if it is multicentric in all the quadrants, then mastectomy is the best treatment.
Yes.
Otherwise, yeah.
Another is extended in situ carcinoma. What do you mean by extended in situ carcinoma? Your tumor is having more than 25%. DCIS, rectal in situ carcinoma is present. So how do you follow up the case further? Surgery.
Let her go.
So will you give any other systemic therapy or adjuvant therapy for the patient? You are not a mastectomy for the patient.
Yes, sir. So after mastectomy, she has to be given adjuvant therapy, radiotherapy. Radiotherapy can be given if there is a margin positivity or a lymph node, lymphovascular invasion, and lymphovascular invasion. And for a receptor status is positive, she has to be given a hormonal therapy. As she is a postmenopausal woman, aromatase inhibitors like letrozole has to be given, and before starting, bone density scan has to be done.
Always your treatment, you should talk. You should talk for your patient. What you are going to do for your patient.
Yes, sir. Yes, sir. If in the biopsy the ERPR status is positive, hormonal therapy has to be given. She is a postmenopausal woman. Aromatase inhibitor has to be given, sir. Letrozole.
So
and
which one you will give first?
Sir?
You said you are going to give a chemotherapy as a first indication. You said then you are saying the hormonal therapy. Which one you are going to give first?
Chemotherapy.
This is ERPR positive lady, and there is a node is there.
Radiotherapy. Sir?
Will you start on a hormonal therapy first or then chemotherapy, or will you start chemotherapy first and then hormonal therapy? Or you will give simultaneously both?
Chemotherapy first, sir.
Why?
Because it's a systemic, means micrometastasis and everything. If there is any micrometastasis and all, it will be dealt by chemotherapy.
You combine both. When you combine hormonal therapy and chemotherapy.
Yes.
You should never do that. Okay. Either you can give, there is no, but why we want to give hormonal therapy second is because chemotherapy is a short duration. You will finish the chemotherapy within the 6 months or 6 weeks. You will finish. Then you should give the hormonal therapy. Hormonal therapy and chemotherapy should not be combined together. So you look only for ERPR or any other markers you will look for.
HER2/neu and K67.
Is there is to tell the tumor whether it is aggressive tumor or not? What are the other methods you have?
if luminal A, luminal B.
That is based on these three. Other than
Yes.
this luminal A, B. Any study on the ploidy?
Aneuploidy.
Aneuploidy will be
Nottingham's prognostic index.
What is it?
Sir, in that they'll point to 0.2 plus tumor size in centimeters plus N staging. For N staging,
All
they'll
plus.
give yes.
All plus or into? Multiply
Plus,
or you will
sir.
add? All three.
Add, sir. Plus. For tumor size, it's multiplies 0.2 into tumor size in centimeters plus for N staging 0 for N0 1 N1 to 3 it's 2 and more than 3 it's 3 and histopathological grading 1 to 3, so all has to be combined, and if the score is more than 5.4 it's a bad prognosis, and if it's less than 5.4, it's a good prognosis.
So aneuploidy, cytometry, when you are doing this, the S phase is more, all are significant. How do you grade? What is grading?
Bloom-Richardson grading, sir.
What are the things you look?
Tubular formation, mitotic figures, and aneuploidy. Sir?
What aneuploidy? So this patient has two synchronous tumor. Any other site you will look for tumor?
Ovarian tumor. Ovarian tumor. Ovarian tumors.
Ovarian tumor. That is why you are saying BRCA1. I'm not asking that on that. Second primary tumor, as here, there's any other synchronous tumor you can expect. Here, what is the role of P56 here?
P53 tumor. In relief from many syndromes.
Okay, we will not go much there. What is the prognosis for your patient? How will you follow up the patient?
A patient has to be followed up every 3 months for the first 2 years, and every 6 months for the next 3 years, and every yearly for after that.
What all you'll do in the follow-up?
This patient MRI mammogram could be done. Because bilateral, both sides we operated. So
if you have done a bilateral mastectomy, then
First
I
clinical.
will do a bilateral mammogram then in follow-up or MRI.
MRI.
No, why will you do either of these?
What is the role of MR mammogram here? And will you do a PET scan?
PET scan can be done.
MR mammogram, when will you do?
MR mammogram in recurrence to rule out recurrence and for differentiate between scar tissue and tumor. If any implant has been done after implant recurrence.
In your follow-up, you will first clinically examine the patient for any nodules or any kind of asymmetry or any new lesions. You will examine the chest wall and the axilla as well. And if there is anything suspicious, then you will go for an ultrasound of the particular Yeah, if you
local
have
lesion.
conserved, if you have conserved the breast, then a yearly mammogram must be done. And if there is any implant or any reconstruction from a flap or something like that is done, then you will go for an MRI.
MRI.
So I'll ask you one bonus question. If your patient is a BRCA positive patient, 1 or 2 maybe, then what targeted therapy is available? Any adjuvant targeted therapy that you know of?
We are if for head to new positive, trastuzumab can be given, ma'am.
Yes, but if it's a BRCA positive, there is a targeted therapy available, olaparib, which can be given.
PARB inhibitors.
PARP inhibitor. Yes.
PARB inhibitors.
Any other questions, or we can conclude?
Will you do any screening for this? Now you have 3, index cases. And what you will do to the family?
We have to keep her family. Actually, she doesn't have any child, sir. We can screen the children of the other sisters by yearly mammogram and early surveillance.
No, firstly, there should be a genetic counseling. First, there should be a counseling. Then there is a testing, and then there is surveillance.
Okay. So, do you have any questions to be asked? Now it's your turn to ask question.
Don't feel bad. You are welcome to ask.
Very well presented. Good presentation.
And confident answer.
So her teacher is also there, Professor Vijayalakshmi Madam. Madam, would like to hear from your voice. Any comments from you?
Sir, presented well, should concentrate more on discussion, sir.
Sure.
So, you have presented very well. Discussion part, you should still read some more.
Okay, ma'am.
Thank you, Professor Anurag, sir. Thank you for joining today. In spite of very lately informing you. And thank you all the faculty. Rajita, I wish you could join for the endocrine and breast cases if there are any. Definitely, it will be knowledge sharing for all the benefit of the young ones.
I also like to see all my teachers here. I'm very happy to see them. And it's also a lot of learning for me as well.
Okay, so the knowledge is for everyone to get benefited. That is all. So who gives the knowledge is truly voluntary. So thank you. Thanks for spending time with us. And we wish you a good career to settle down faster. We do your wish and way. Very happy to see people coming back as faculty. It's definitely a proud moment for all of us. Other faculty, Sahai sir, Kanna sir, anyone would you like to add any comments, sir?
Right, sir. Thank you.
Thank you, sir. Thank you. And I thank both the students, Dr. Madhivatani and Dr. Solai Ramapriya, for making this evening possible. And thank both the faculty, Jailal sir as well as Vijayalakshmi madam, for contributing the postgraduate to present here. Looks everywhere, exams are happening. So we have some challenges in handling, but I'm sure we will be having Friday classes as usual. So good luck to you, friends. And Dr. Solai and Dr. Madhivatani, this is a platform to just restock yourself. There is always avenue to improve upon. So ensure and fill up the areas where you have the knowledge lacuna. That is all is from our side. And wish you all the very best. And then look forward for it another Friday. Thank you, faculty. Thank you, students. Good night.
Good night, everyone.
Thank you.
Good night.
Good night. Anurag sir, thank you very much. Kanna sir, thank you very much.